my signals are not very strong.
Yeah, the signals are not strong. You better continue without picture, sir.
Anyway, he doesn't have a picture. No, Dr. Anand. No, talk.
Yeah, signals are very weak here, madam.
But we can hear your voice beautifully.
Yeah, I'm in Vellore. I try to start my video.
Oh, now yes, we saw you. Yes.
So now your video is being seen.
Hello. Can you see me?
Yes, very well.
But I can't see you, anybody.
But your video is breaking, sir.
The signals are very weak here.
Hello.
Hello.
Hello, Anand sir. Hello.
Hello.
Sir, this is Jaya. So we are live so that we can start.
Sir, shall we start the session?
Yes, sir. Yes, sir. Please go ahead.
Any Dr. Nirmala Devi has not joined.
Sir, madam ku link வந்து அவங்க இதுல பார்த்துட்டு இருக்காங்க. I just put her in.
Dr. Annie, did you call Dr. Rachita, madam?
She joined. She did.
The madam came. She finished her dry run and she's back. She'll again come back.
Okay.
When we are going live, I can ask her to come, sir.
Oh, ma'am, we are live. We can start.
Shall we start?
Yes, sir.
Okay. Dear IADVL members, good evening from IADVL Tamil Nadu. This year's initiative is like we have started IADVL TN Academy, and Professor Anandan sir is the chairman. Professor Nirmala Devi madam is the vice chairman, and Dr. Annie is the coordinator. And in this series, the special focus group on trichology, we are organizing CME on patchy hair loss, and we have some interesting speakers and panelists for this session. So to begin the session, I request IADVL TN Academy Chairman Dr. Anandan sir to give the welcome address.
Thank you, Dr. Badmanandan. And I take this opportunity to welcome the EC members first, starting from our President, Dr. Maya Vedamurthy Madam, Secretary, Dr. Badmanandan, Joint Secretaries, Vice Presidents, and my dear colleagues, my own colleagues, Dr. Nirmala and Dr. Annie, and the wonderful speakers who are going to make this webinar very, very lively and shell out important practical tips for the future and practical uses. And I also welcome all the members, esteemed members, without whom this webinar will not be a grand success. I welcome all the members, and I also welcome the audiovisual personnel who is going to play a vital role in maintaining the uninterrupted services in this webinar. So if anybody is left out, it is quite unintentional. Consider them, that they are also being extended with a warm welcome. So I welcome everybody, one and all, to join this webinar. Welcome all. Thank you.
Thank you, sir. We also recognize the contribution of Dr. Reddy's Grandira division in making this program successful. They have committed for continuous support throughout the year. Now I request our IADVL Tamil Nadu President, Dr. Maya Vedamurthy ma'am, to deliver the keynote address.
Good evening. Thank you, Dr. Padmanandan, and thank you, Dr. Anandan. Good evening, respected teachers, seniors, and dear colleagues. A warm welcome to one and all. It gives me immense pleasure to welcome today's speakers, Dr. Murali Narasimhan and Professor Rajita Dorath, and also our esteemed panelists, Dr. Praveen, Dr. Lindsay Peter, Dr. Kumaresan, and Dr. Jayanti, along with the moderator, Dr. Kali Suran, who will impart practice pearls in treating patchy hair loss. I also thank the Tamil Nadu IADVL Academy for their effort in organizing the CME on this important topic. Although hair is a totally dispensable structure in human beings from a physiological point of view, shedding a handful of hair or even a patchy hair loss causes psychological problems. Whether we are a pure clinical dermatologist, a cosmetologist, or a trichologist, we all end up treating such hair loss patients almost every day, more so in this COVID era. So I'm sure today's webinar will enrich our knowledge to treat our hair loss patients more effectively and more satisfactorily. With this, I hand over the platform to the organizers.
Thank you, ma'am. Now we'll straight away go to the scientific session. The first session will be by Professor Dr. Murali Narasimhan, Professor and HOD, Department of Dermatology, SRM Medical College. The topic would be differential diagnosis and workup of patchy hair loss. This is a
Vishrut.
Yeah, Vishrut, you can stop sharing. Yeah, this is a short introduction of for Dr. Murali Narasimhan.
Can I share my screen?
Yeah, you can share your screen, Dr. Murali.
Okay.
I welcome Dr. N. Murali to deliver his talk on differential diagnosis and workup of patchy alopecia. Yeah, your screen is being seen, Dr. Murali.
Sir, okay. I'll just start the.
Yeah, make it into a slideshow.
Okay. First of all, my heartfelt thanks to people in the IADVL TN Academy for asking me to speak, and it's really an honor. Without taking much of your time, I hope to finish my session on time. So, patchy alopecia, what is the differential diagnosis and what is the workup that we need to do? That's the topic. Some of the images used in this presentation have been taken from textbooks and journals, and some of the images are my own patients whose consent I've taken. So what do you mean by patchy? The dictionary meaning is that it's existing or happening in small isolated areas, and similar words that are used to describe hair loss in our literature are uneven, irregular, mottled, variegated, moth-eaten, etc. So the objectives of this short talk are how to examine a case of patchy alopecia in a busy OPD or in a spotter kept for the exam, briefly discuss and know about the clinical differential diagnosis of patchy alopecia in children and adults, and a very brief description of how to evaluate patchy hair loss using history, examination, bedside tests, and other invasive tests. So this is a patch of hair loss. This is classic alopecia areata, teenager, young adult with one or more discrete round areas of alopecia commonly affecting the scalp. It's a very disturbing problem for most of the people, and the quality of life takes a hit. So what can you do in a minute in your clinic or in an exam? Greet, take consent from the patient for examination, make sure to sanitize your hands simultaneously. Start by inspecting the affected area, note the size, shape, pattern of hair loss on the scalp, ask for hair loss at other body sites, quickly inspect the beard, eyebrows, eyelashes, and body hair if needed. Look for nail changes and take a look at the palms and soles quickly. Examine the lymph nodes in the occipital scalp and in the retroauricular area. Then you examine the alopecic skin doing the Brackett's test. The skin fold is taken between two thumbs and you look for follicle openings, tethering of skin and the texture. Take out your lens, try to identify any visible marks like exclamation mark hair or broken hair or tufts of hair. Look for scalp changes like scaling, erythema, pigmentation, etc. Try to identify regrowing hair, vellus hair, white hair, heterochromia of the hair shaft, terminal hair in a patch. Do a hair pull test from the margins to see for disease activity. And yes, so how the first question that we have to answer is it scarring or non-scarring? For that, the clinical signs are very the clinical signs are very important. Atrophy, loss of follicular openings and tufted hair are usually seen in scarring alopecia. And in non-scarring alopecia, the scalp is usually smooth, there is no atrophy, and you can see a lot of follicular openings. So, what are the causes of focal patchy non-cicatricial alopecia? Commonly, you have alopecia areata, tinea capitis, non-inflammatory type, trichotillomania, traction alopecia, secondary syphilis, perinevoid alopecia, and congenital hair shaft abnormalities. The causes of cicatricial alopecia are numerous, but broadly they can be classified as developmental, traumatic, neoplastic, follicular inflammation with pustules, follicular inflammation without pustules, and dermal inflammatory skin disorders of both infectious and non-infectious etiology. We'll take a look at some of these. And what are the common tests that we do? Mainly clinical diagnosis. Then you have Woods lamp, dermoscopy, trichoscopy, hair root examination, a scalp biopsy, serology for lupus and syphilis, CBC, and thyroid function test. These are the most commonly done tests in clinical practice for patchy alopecia. So, alopecia areata, this is the classic type. Then you have the diffuse type. In the diffuse type, you can see that there is a triangular area on the scalp where there is loss of hair and there is diffuse thinning also. So this triangular area, it can mimic either a traction alopecia or a congenital triangular alopecia. That has to be kept in mind. Then you have the Euphiasis pattern. In Euphiasis pattern, again, traction alopecia with fringe sign needs to be there, and frontal fibrosing alopecia also will mimic Euphiatic type of alopecia. This Sifo, which is the reverse of Euphiasis, you see that the pattern is mimicking an androgenetic alopecia. Then you have the reticular and the linear patterns of alopecia areata. And then you have the alopecia totalis and the universalis, which we are all aware of. This can affect the beard also. Sometimes even body hair, including forearms, can, as shown in the picture over here, can be affected. Always look for eyebrow and eyelash loss in any case of patchy alopecia. Take out your dermatoscope and then you might find some of these findings. Black dot and vellus hair will be seen. Hoodability sign because of thinning of the hair shaft at a focal area. This can also be demonstrated by dermatoscopy. Then you can have pigtail hair and the classic exclamation hair, which gives you reasonable specificity for the diagnosis of alopecia areata. Coming on to tinea capitis, which is another common condition. The non-inflammatory black dot tinea and gray patch type, these are non-scarring. Usually they resolve well with treatment when it is initiated. But this chirion, which is one of the inflammatory types of tinea capitis, this can cause scarring. And in case it is misdiagnosed as an abscess and gets cut by the surgeon, again that can cause scarring. Even when it heals, many of the hair follicles can get damaged, leading to cicatricial alopecia. In this condition especially, you have to look for the occipital nodes for involvement, which is usually due to a reactive pattern. And on dermatoscopy, sometimes you can get comma hair, black dot, and interfollicular scaling, which will provide additional clues. And KOH mount of the hair will help us to identify whether it's ectotrichs or endotrichs. Another common condition is trichotillomania. Here you find that there are vertically broken hair and upright regrowing hair on dermoscopy. And you can see that hair are broken at different levels. There are different levels at which the hair is cut. So you always look for underlying psychiatric problems in these patients. Another condition is tractional alopecia, where putting the hair into a tight bun or combing back into a tight ponytail can cause hair loss. See, this again it can resemble trichotillomania as well as frontal fibrosing alopecia. One peculiar thing is use of a slide. Actually, the patient has used the slide to hide the area, but using the hairpin at the same site repeatedly, having the same hairstyle, this we've noticed with a lot of our nursing staff. Then you have alopecia artifacta. Okay, this is another condition which is associated with dermatitis artifacta. The same patient might inflict self wounds on the scalp, which can cause again scarring alopecia. Syphilitic moth-eaten alopecia, again this is not as rare as it is thought to be, and hair regrowth is there once treatment is initiated. It will be associated with other signs of secondary syphilis. Then folliculitis, post-folliculitis and post-furuncular alopecia can occur. On dermoscopy, you can find interfollicular red area. A pustule is there. Once this pustule goes, there is crusting and scaling. And once there is healing and fibrosis, alopecia can result. In dissecting cellulitis of the scalp as a part of follicular occlusion tetrad, you can have alopecic patches of cicatricial alopecia on the scalp. And again, acne keloidalis nuchae. So here you have the clinical aspect where you have the alopecia and perifollicular erythematous papules on the neck, and then it develops into a large keloidal plaque with pustular and crusted lesions, again causing alopecia. Now dermoscopy, when we do, you find these tufted hair. This is because the adjacent follicles get merged together and then there is fibrosis occurring in the interfollicular area. That is why we get this perifollicular pustules and tufted hair in acne keloidalis nuchae. And then the lichen planopilaris, another common cause of cicatricial alopecia. Here you find hair casts as seen in the picture just above the bottom. This can also have hair shaft abnormalities like trichorexis nodosa. And in the interfollicular area, you can see a violaceous area that is also suggestive of lichen planopilaris. Here you find that the inflammatory cells on histopathology are found around the infundibulum. Now infundibulum is the area where you have the stem cells. So once this area is damaged, it is going to cause permanent hair loss. Whereas in alopecia areata, it is a peribulbar infiltrate. That's why when inflammation subsides, hair regrowth is possible. Then you have Graham-Little-Picardy syndrome, where it's a rare entity with patchy alopecia of the scalp, non-cicatricial alopecia of axillary and pubic hair, and a lichenoid follicular eruption. Then our DLE. In the later stages of DLE, you can get these findings along the margins. You can see red dots, some yellow dots representing open follicles, and arborizing vessels. These can be seen. These are clues to the diagnosis of discoid lupus erythematosus on dermatoscopy. And then we've seen frontal fibrosing alopecia, which I said is a differential diagnosis for oophiatic pattern as well as traction alopecia. Now, between LPP, FFA, and DLE, you have this table where on dermatoscopy, you find fibrotic irregular white dots and gray hairs and small hair tufts. Whereas in frontal fibrosing alopecia, perifollicular erythema is quite prominent and there are no vellus hair, and On the eyebrows, if you take a look, you will have pink gray dots. And in DLE, you have large yellow dots, which are follicular keratotic plugs. And there are thin radial arborizing vessels from the yellow dots, as I've shown in the previous picture. Another condition, follicular mucinosis, can occur where you find that histologically there is deposition of mucin in the follicle, maybe primary or secondary to mycosis fungoides. This can also cause alopecic patches, both in the scalp and in the body. And then morphe can also result, especially linear morphe, can result in alopecic patches. Then pseudopelade of Brock. Many people do not use this term nowadays, and it's considered as a non-specific thing. Here, white dots with reduced follicular openings and interfollicular brown area and white dots are seen. Usually it is not associated with much inflammation, but there are no clear-cut differentials. Again, in bullous diseases, we have seen that it can pemphigus, pemphigoid, cicatricial pemphigoid, pemphigus foliaceous, all these things can cause lesions in the scalp with erosions. When they heal, they can cause diffuse as well as focal and patchy hair loss. Cicatricial pemphigoid, yes, it causes cicatricial patches on the scalp. Again, herpes zoster, post-zoster cicatricial alopecia and trigeminal trophic syndrome have been reported. And coming to hair loss in children, you find that this is not a very common condition, but you can easily pick it up. There is a congenital triangular alopecia. There is a triangular patch of alopecia in the right temporal scalp, looking like a lancet. And when you do a dermatoscopy, you will find a lot of white dots and vellus hair. On biopsy, you will find a lot of vellus follicles, but no terminal hair will be seen. Aplasia cutis congenita, this is another cause in newborn babies. Once the child grows up, it will leave a scarred area like this, and there will be absolutely no follicular openings and appendages. Nevus sebaceous, again it can present with hair loss on the scalp. There will be large yellow dots that are seen. And then you have perinevoid alopecia, an alopecia surrounding a nevus. There is an interfollicular gray area with vellus hair and pinpoint white dots on dermoscopy. The nevus may disappear after this phenomenon occurs. And then you have occipital alopecia of infancy, where most of the occipital hair go into the shedding phase at 2 to 3 months of age. And this can also cause alopecia in infants. Psoriasis, yes, psoriasis can also cause hair loss, especially pityriasis amiantaceae. When the scale is removed, you can have hair loss over there. Dilated red loops on dermoscopy is quite diagnostic, and then you have these silvery white scales. Psoriasiform alopecia is also noted with treatment using adalimumab and infliximab. This is recent from literature. Then you have seborrheic dermatitis, which can also cause patchy hair loss sometimes. And sometimes androgenetic alopecia and female pattern hair loss also they occur. Androgenetic alopecia may occur only on the vertex. Female pattern hair loss can actually central centrifugal cicatricial centrifugal alopecia can mimic FPHL. Okay, now that we've seen most of the clinical conditions, what do we do to work up these patients? We have a long list of clinical toolkits: hair pull test, daily hair count, standardized wash tests, and so on. But the most important ones are the hair pull test that we can do, Woods lamp examination, and trichoscopy. Trichogram or pluck test can be done. Then microscopy of the hair can be done for doing checking for hair shaft abnormalities, then polarizing microscopy, electron microscopy, global photography, video dermoscopy and trichoscopy, confocal microscopy. This confocal microscopy of the scalp is a non-invasive tool for it is maybe in another 30-40 years it may or maybe 10 years even, it may completely replace scalp biopsy. Now the trichoscopic algorithm for diagnosing alopecia localized type, look for the hair follicle ostia. If it's intact and you see yellow dots and exclamation hair, then it is alopecia areata. If you see black dots, trichorexis and comma hairs, then it could be tinea capitis or trichotillomania or trichotillomania. In scarring alopecias, if there are black dots and trichorexis, again you can have tinea capitis. If there are follicular pustules with hair tufting with more than 5 follicles, you arrive at folliculitis decalvans. If there are no pustules but there are white dots, then you consider lichen planopilaris and its variants, frontal fibrosing alopecia, etc. If there are red dots, then scleroderma, pseudopelade, and if there are red dots, again you can think of discoid lupus erythematosus. So in the recent development in trichoscopy is that there is a confocal thing and also an ultraviolet enhanced trichoscopy which can pick up conditions like pityriasis and tinea capitis. Now, regarding scalp biopsy in patchy alopecia, the site to be chosen should be clinically active with primary morphologic features and do it from a place where the hair pull test is positive. Now, examination of a sample taken from end stage disease is usually not productive. While doing a scalp biopsy, we can use local anesthesia with epinephrine, and you should wait for at least 10 minutes for maximum vasoconstriction. And the most common method used is a 4 millimeter punch biopsy. We ideally take 2 specimens, one for horizontal sectioning and one for vertical sectioning. And when we take a biopsy, the direction of the biopsy should be in line with the follicle course in the scalp, so that we obtain complete hair follicles and not transected follicles. So this is how we position a patient for scalp biopsy, either sitting on a stool and leaning over or lying down with face down. Now, normal hair findings are as follows. Like if you do a 4 mm punch biopsy, you will find 30 to 45 hairs, and then telogen hair is less than 15%, terminal to vellus hair ratio is 2:1, and follicular units are 12 to 14 with 4 to 6 hair. So this is what we normally see. Now, if the biopsy provides a diagnostic clue, usually we can pick up systemic diseases like DLE, sarcoid, lichen planopilaris, necrobiosis, lipoidica, etc. Infectious conditions can also be picked up, or sometimes even neoplastic conditions like morphic form of basal cell carcinoma, squamous cell carcinoma, metastatic carcinoma in the alopecia neoplastica form, lymphoma and adnexal tumors, etc. If biopsy is not diagnostic, the dermatologist should suspect a hereditary disorder, trauma, or injury. The other lab studies in patchy alopecias include, we have to do it on a need basis. It may be prudent to evaluate the patient for potential mimics like syphilis. Then bacterial and fungal cultures need to be done if infection is suspected. To rule out overlap conditions, that is autoimmune disease or stress, we can use thyroid function tests and anemia. And you also have to consider problems with systemic correlation. If all these tests are not suggestive, then we can do a zinc evaluation and vitamin D levels in alopecia patients. Vitamin D resistant rickets is also known to cause alopecia in children. And the other workup for alopecia areata would include thyroid screening, but it is not mandatory, as thyroid disease and alopecia areata are not very much correlated clinically or casually. It can be done in long-standing cases, especially with persistent symptoms. And then KOH mount, scalp biopsy, hair pull, pluck test, etc. And trichoscopy nowadays, with the help of proper history, clinical examination, and trichoscopy, we can diagnose nearly 80 to 90% of both scarring as well as non-scarring alopecias. However, scarring alopecias, even histologically, we need real expert to give proper diagnosis. Thank you.
Thank you, Dr. Murli. That was a great presentation. You almost covered everything for patchy alopecia, the clinical features, that the diagnostic workup, and everything. And we'll take up the questions. We have a few questions. We'll take up the questions once Dr. Rachita Madam completes her session. You both can take the questions. Once again, thank you. Now the next session. Next session is going to be on what to do and what not to do in the management of alopecia areata by Dr. Rachita Durat from Mumbai. She's one of the authorities on trichology, qualified trichologists in India. I welcome Dr. Rachita Madam to deliver her talk.
Ma'am, if you could just, if you allow me to just unshare your screen, I would just want to present the CV of yours. Thank you.
Yeah, we should just, the CV slide of ma'am, please. Dr. Rachita Durat, Professor and HOD, Department of Dermatology, LTM Medical College, Mumbai. She has 30 years of experience as dermatology teacher. She is an international faculty, especially on trichology topics. I welcome Dr. Rachita ma'am to deliver her talk.
Yeah, I'll just want to share my PPT.
Yeah, you can share your this thing, ma'am.
Good evening, everyone. This is a very good topic given to me by...
Ma'am, yeah.
Yes, am I audible?
Yeah, you are audible. Make it the slideshow, ma'am. Yeah, ma'am.
So this is a very good topic given to by the team of the conference, that what to do and what not to do in the management of alopecia areata. So I would like to begin that when you see a case of alopecia areata, sometimes there are many questions arise in a clinician mind, that which treatment would be work for this patient, the best treatment for this patient. And when we see our guidelines, there are various guidelines being published. This is one of the guidelines, is Italian guidelines, and then we have alopecia areata consensus of expert published this year. And however, none of the treatments or devices commonly used to treat alopecia areata are specifically approved by FDA. Even we are using intralesional steroids since more than 30-40 years, which is not FDA approved. So that's why I want to give the message to everyone that not necessary that you have to use FDA approved treatment every time. Now, if you look at, we have been taught that alopecia areata should not be treated single patch of short duration, because spontaneous remission is known in single patch of alopecia areata. But I have a different opinion for that. I'm going to ask you the question that no treatment is a viable option for patients with a single patch or not. So this was a study I would like to share to you, that it was done by Ikeda between 1947 to 1963, that if the patient is having single patch, less than 6 month duration, then risk of developing to totalis or areata is very low. But however, the patch is more than 6 month duration and less than 12 months, then development of a risk of developing totalis and alopecia universalis is 30%. But however, they can go into chronic alopecia is by 65%. And single patch is more than 12 months duration, then it is a 100% chance of developing chronic alopecia areata and 45% chance of developing alopecia totalis or universalis. So a very high chance. Now let's look at this. What I would like to say that 35% of individual having single patch those persist beyond 6 months will resolve by 12 months, only 35, and rest will persist and evolve into chronic alopecia areata. So spontaneous regrowth in solitary patch, which is more than 12 months, is unlikely, and risk of development of alopecia totalis is very high. Now let's look at multiple patches. What is a natural outcome? This is what I'm talking is those who have not been treated. So these are untreated cases. So in multiple patches within 6 month presentation, risk of developing chronic alopecia areata is 35%. However, if they present at less than 0 to 6 years, then it is 100% development of chronic alopecia areata, 45% development of alopecia totalis. And if they present between 6 to 12 years, then risk of development to chronic alopecia areata is 40%. So amongst those with the chronic alopecia areata, 30% ultimately develop alopecia totalis and 15% alopecia universalis. Even if you take 30%, it is a huge number. Now, for that, you have to understand what do you mean by chronic alopecia areata. So in my opinion, no treatment option is not viable for patients with the chronic alopecia areata, patients with having a alopecia, even single patch more than 6 months duration. Now, what do you mean by chronic alopecia areata? So let's understand the definition of chronic alopecia areata is the alopecia areata that continues beyond 12 months and recalcitrant which fails to respond in the first therapy within 6 months. So for practical purpose, all solitary lesions that have persisted longer than 6 months should be considered for topical or intralesional therapy. And all lesions that have persisted more than 12 months, that means chronic alopecia areata, who have failed for 6 month trial of topical or intralesional corticosteroid should be considered for topical immunotherapy or any other systemic therapy. Now I'm going to talk about what systemic therapy, what topical and what intralesional. Now, everyone uses topical corticosteroid because it is a first-line therapy for children as well as in adults who refuse intralesional injections. And however, you should know that it should be used continuously for 6 to 12 weeks or at the most 3 to 6 months. The problem what I have faced in my practice are the folliculitis is very common, especially in Mumbai climate. And most of our patients use unchecked because there is no regulatory here. So I have seen local skin atrophy, telangiectasia, and therefore topical corticosteroid I don't use on a regular basis. Second is important is what not to do in alopecia areata, that is topical use of topical tacrolimus. I know most of the clinicians prefer to use tacrolimus so that side effect of corticosteroid, topical corticosteroid can be avoided. But however, latest studies on topical tacrolimus formulation has shown that it is less effective and it lacks penetration into deep dermis. No. However, eczema study has been shown promising results in pediatric cases. So one can use eczema also in pediatric alopecia areata. Now, what I want to do if patient has single patch of alopecia areata. Now let's take children. I would prefer to use short contact anthralin therapy with or without minoxidil, or short contact therapy with or without calcipotriol, because we have seen very good results with short contact therapy. For adults, single patch, intralesional steroid would be the first choice, and later followed by anthralin or with calcipotriol. In the patient with multiple patches of alopecia areata, in children, again, I would prefer anthralin with minoxidil, but my second choice here would be DPCP. I have seen few patients improving with 30% TCA. Those who can't afford DPCP, you can, or you don't have the DPCP. I can't say the afford. The DPCP is not very costly, as been there is a belief that it is very costly. It is not very costly. You can use TCA, Excimer, or you can use hair tincture. But however, in adults with multiple patches, I would prefer, the first choice would be intralesional steroid, anthralin, calcipotriol. Third would be DPCP, and my next choice would be systemic steroid cyclosporin. Before that, if the patient is affording, my next choice, rather than using steroids and cyclosporin, I would go for tofacitinib, that is a JAK inhibitor. Now, let me share some results of short contact therapy. This was short contact therapy. This was alopecia totalis with short contact therapy. Again, this is short contact therapy. And this patient, we have used short contact therapy with the mini pulse to show that the combination, and then this was a speed skull study. We have instructed patient to use short contact anthralin on one side of the skull. And you can see the difference between split skull study, that the portion which has used and short contact therapy and mini pulse has shown robust regrowth. Now, next, coming to use of systemic steroid in pediatric population, most of the clinicians start using systemic steroid for multiple patches of alopecia areata, more than 50%. But I have my own reservation to use systemic steroid in pediatric population. However, you can use systemic steroid in adolescents group with caution. Now, why I'm saying that, even short course of systemic steroid, that is up to 7 days, cannot produce a significant suppression of adrenals. However, even 2 weeks therapy may cause adrenal suppression, which can last for 1 year. And in pediatric population, we don't want to retard their growth, which is the most important than treating alopecia areata. And therefore, I generally don't prefer to use systemic steroid in children less than 10 years of age. Apart from that, retardation of hair, growth, there is also weight gain and menstrual irregularity seen in female adolescents. Next would be my choice is topical immunotherapy, and I have seen excellent results in patients, children, especially children with extensive alopecia areata. And I would like to share some of the before and after results. This was a young boy, a 4-year-old girl, alopecia subtotalis, got very good improvement. Next patient, also alopecia subtotalis. Ophiasis pattern also responded to DPCP. And this was a child who was, when she came, she was just 3-year-old. And we started DPCP. Within 2 months, you can see the response. There was fine hair regrown. And this was other view of the same child. And after 1.5 years, she had got very good response. And this was after 2 years. And she is still following, because any treatment for alopecia areata is not curative. Now she gets only 1 or 2 patches, the small patches, which I treat with the topical agents, not with the DPCP. So point is that even after DPCP is stopped, there was no relapse. She's getting only 1 or 2 localized patches of alopecia areata, which can be treated easily with the topical agent. Now let's understand how to prepare this DPCP solution. It's very easy, it's not very costly. It comes around 1 gram, comes around in 4,000 plus. So if you take 1 gram and dissolve into 50 ml, you get 2% solution. And this will be your stock solution. And later on, when you want to prepare different concentration, you can prepare by taking this stock solution and taking this acetone, and you are getting your percentage of your desired one. I generally don't store in amber color this type of the bottle, because the moment we had done some experiment that multiple times if you are opening this bottle, the acetone evaporates and that increase in the concentration of DPCP. Instead of that, we use this kind of the cramp vials of lignocaine. If you don't get amber color vial, you can wrap this white bottles and you use for storing DPCP. Now, first sensitization have been taught that you do sensitization on buttocks or back, but over the time we have realized that sometimes if the sensitization is very bad, then it can give rise to very bad patch on a back or lower buttock. So we are doing sensitization only on the scalp, and this was a problem that if you do it on back, you get a bad pH. I always start with, after sensitization, I don't start with 0.0030 and 1%, because patients do not get any kind of hyperreactivity, or neither they get any benefit. So you are wasting the patient's time and your time. So I start with only 0.2001% and escalate gradually the concentration. Everyone knows about the side effects. I'm not going to go into the detail. This patient had taught me that every time if you increase the concentration, you should do only in the small area, apply on the small area, observe how the patient is reacting, and then you apply on a larger area. In this patient, I have gradually escalated the higher concentration, but applied on the larger area, and she got severe reaction. Now, what I don't do it for, or what I rather do it in single or multiple patches of alopecia areata in adults, though I prefer to use ILS in adults, those having a less than 50% scalp involvement, but I'm going to talk about more on dose, frequency, and when to stop. So dose or Triamcinolone, everyone knows about that. You require lower doses for eyebrows, but you can use 5 to 10 milligram of Triamcinolone per ml on the scalp. But I differ for this concentration, simply because we had done the study on that. We had done the study of 1.25% and 2.5% milligram. But Jerry Shapiro and his group has done study of 2.5% versus 5 milligrams, not percent, 5 milligram versus 10 milligram. And if you see, this was 2.5 milligram, this was 5 milligram, this was 10 milligram. Now, if you see the graph, there was no difference in hair density with the different concentration. So why to use higher dosing? So we wanted to know whether lower than 2.5 milligram works equally with 2.5 milligram per ml or not. So this was one of my students have done thesis on that. And this is 2.5 and this is 1.25. Not percentage, it is milligram per ml. And we had treated 60 patches. And what we have seen that in 2.5 milligram, you can see good hair growth than 1.25 milligram. So why should go higher concentration? You should not go to the lower concentration of 1.25 milligram. I feel 2.5 milligram per ml is optimum beneficial concentration in alopecia areata. And then you get additional benefits when you use a lower concentration, that is 2.5 milligram. It minimizes skin atrophy and telangiectasia. It reduces adrenal suppression. The most important is that the larger area can be treated with larger volume without any having a side effects of skin atrophy. Now, dilution. People dilute with lignocaine, people dilute with sterile solution. Which one is better? Lignocaine containing some methylparaben or propylparaben should be avoided because they can increase the risk of flocculation of the steroid. And second thing is that lignocaine as a diluent stings more than your sterile saline. I usually prefer sterile saline. Now, how frequently one should use? It should not be used every 3 weekly. It is 4 to 6 weeks. Some of the medical colleges, residents are using every 3 weekly. I don't know who taught them every 3 weekly. And we are seeing that skin atrophy, especially in children, because skin is very thin. When to stop? When you don't see the response. If you don't see the response within 6 months, one should stop this ILS because there's a decreased expression of thioredoxin reductase 1 in the outer root sheath, which decreases glucocorticoid receptor activity. And this was a case. I would like to share what happened in this case. Some blunder happened in this case. However, luckily he didn't have any side effects of corticosteroids. This was a small patch, an 8-year-old boy, which has started here in 2018 as intralesional steroids with lower concentration. Of course, this was in June, this was in July, August, September, again September, this was in November, December, February 2019, and there are many more. So I extracted the history and it was 11 intralesional steroid in 18 months with no response. First of all, this patient, the small patch of alopecia should not be treated with intralesional steroid. And one should understand he was treated for 11 intralesional steroid, which should not be done. Now, what should not be done? This is a good video, which I observed in my OPD that many times we refill the dilute this triamcinolone acetonide diluting with normal saline and we keep it. By the time you finish the other biopsy and the residents comes here and just start injecting without realizing there is a settlement of steroid at one side. So you should know that you have to re-agitate this syringe, mix steroid properly into the saline, and then inject. So let's move on to this. Can we use microneedling and triamcinolone acetonide? And Dr. Chandrasekhar has done study, but however, our experience of using microneedling acetonide is not great. So we are not using it. Let's move on to the safety of methotrexate in combination of mini pulse. Yes, it can work for severe alopecia areata. However, you should know that how frequently you are to use and how long you should be used. So I would like to share this low dose systemic methotrexate, where it has shown that there was a good improvement in 14 patients. And what it says that less than 14 months duration of alopecia areata show very good response. And if the duration of alopecia areata more than 24 months, then there was no clinical improvement. So this was study, this was the systemic review and meta-analysis of methotrexate for alopecia areata. It says that treatment takes 6 to 12 months for complete regrowth. Response to methotrexate is better if the duration of disease is less than 24 months, and it is good response seen in adults than in children. Now, I'm going to ask you, how many patients come to us with duration of the disease less than 12 months? Very few patients. In my practice, very few patients come to us with the duration of less than 12 months. Reading this paper, we started using methotrexate in our patients. We are given not for 1 year, but at least for 4 to 6 months, but we have not seen any promising results with methotrexate. Probably people may differ with my opinion. They may have got very good response to methotrexate. Now, there is one more paper that for recalcitrant alopecia areata published by Kabir Sardana, use of leflunomide and short contact anthraline. And the theory behind use of leflunomide is that it is a kind of tyrosine phosphorylation, inhibitor of tyrosine phosphorylation of JAK1 and JAK3. And use of anthraline is due to it inhibits pro-inflammatory cytokines and it stimulates the anti-inflammatory cytokine secretion. However, my experience of using leflunomide is limited. But however, I would like to know from the audience or faculty, have they used this drug or not? My experience with using JAK inhibitor is very much promising for severe alopecia areata and recalcitrant alopecia areata, of which tofacitinib is available in India, which has now, you can say cost effective, like 5 milligram once a day would cost you 8,000 rupees per month. And if you see the long-term safety of this molecule in severe alopecia areata, these are some references. And globally, it was very well studied in rheumatoid arthritis, where more than 4,000 patients were recruited, and they have shown that there was a sustained efficacy more than 6 years and safety profile of 8 years. This was a patient I would like to share with you, that it was a very difficult patient for me, whom we have given systemic steroids, cyclosporin, methotrexate, mesalamine, and DPCP2, but he never got any regrowth in this area. That was a reticular pattern of alopecia areata. Biopsy proven, we had done CD3 staining also. And when TOFA came into the market, we started, and within 1 month, he started showing negative pool test, decrease in trichoscopic features of alopecia areata. And at 2 months, you can see a very good response to tofacitinib. How many minutes are left? Could you tell me? Hello?
Madam, another 3 minutes.
Dr. Rachita, please continue.
We have 2 minutes.
So this is at 2 months. You can see the improvement. This is another patient who was not responding to DPCP, and you can see the improvement in 2 months. This was uphiasis showing improvement in 2 months' time. I'll just show you, this is improvement in baseline, in between, and this. And after 12 months, she got so beautiful hair growth that it was difficult to comb her hair. Still, she is maintaining on the low dose of tofacitinib. This was a patient of alopecia totalis failed to respond to DPCP. Within 4 months, he started showing some hair, and within 1 year, he's got very good response, except an uphiasis pattern and this frontal area. So you can see the response in before and after. And with this, his psychological depression also improved, because earlier he never used to talk to me. Now he is talkable, he's mixing with friends. That psychology is, you need to understand that when you want to give treatment, you can understand patient psychology also, that what is the best treatment for this patient, instead of patient is taking systemic steroid, getting side effects, going and not going, getting much regrowth, and then we are making him to go more depressed. To conclude, there is no uniform treatment for hair loss with guaranteed efficacy. There are some anecdotal reports and case studies. However, DPCP and systemic steroids are used in many studies, and there is also no uniform accepted way to judge the relative efficacy of these agents either. I would like to make this statement that failure to adhere the guidelines stated earlier above on alopecia areata should not be necessarily be considered negligible, again, nor should adhere to this recommendation constitute a defense against a claim of negligence. However, amongst this, I would prefer tofacitinib as an innovative treatment for moderate to severe alopecia areata. And I have seen good response if those having alopecia areata less than 10 years duration. Though books has mentioned, but I have seen very good response having responded in 2 months time if the alopecia areata was less than 2 years. So better to treat early so that you get a good response. And thank you very much for patient listening. So I would like to invite any questions if you have.
There are a few questions.
Yes.
What is your criteria before you take a case for TOFA?
See, one is extensive alopecia areata. Extensive means more than 50%. Okay. I would prefer to use, I will use DPCP or tofacitinib. Now, challenges for DPCP is that a patient has to visit your clinic at least 3 to 4 times a month, minimum. Okay. And it is a long process. So coming to clinic is, if it is easy, if we are staying nearby. Second challenge for DPCP is that pigmentation on forehead is seen in majority of the patients. So some patients do not like that pigmentation on the forehead. Sometimes you can get depigmented macules also. So these are the problems. While if you see in tofacitinib, you don't get much side effects with the even 10 milligram. I have done I'm doing CBC and LFT every monthly, but none of my patients had any kind of the side effects, even during COVID.
Dr. Rachita, Dr. Maya here, nice talk. I have 2 questions, Dr. Rachita, for you. One, have you tried injection betamethasone in place of triamcinolone? And number 2, have you tried topical tofacitinib in a compounded formula? Because I believe that's more suitable than...
First, I will answer your question that betamethasone. Now, betamethasone has been used for, like, there was a study lichen planus. It has shown that it was better than triamcinolone acetate in oral lichen planus. However, if you look at the concentration of betamethasone vial, it is 4 milligram per ml. And if you go according to your using 2.5 milligram of triamcinolone, then you require only 0.4 milligram of betamethasone. That means you take a 0.4 milligram and dilute with 1 ml of saline. Now, this much quantity you require to use it. However, there is a very few study about of using betamethasone versus triamcinolone, which one is better. But if you take that study of lichen planus, oral lichen planus, so betamethasone would be better. So I would suggest someone can take this study and prove that betamethasone is better than triamcinolone. The second question is topical tofacitinib. It should be prepared in liposomal way, and we don't have pharmacy who can prepare like in liposomal formulation. Then only it will be effective. Despite of that, internationally, it has been shown that it is not very promising than it is oral tofacitinib.
Thank you.
Ma'am, there is another question. How long TOFA should be used, and is there any need for tapering, or it can be just stopped suddenly? And what is the rate of recurrence once it is stopped?
Yeah, rate of recurrence, you can, various studies have a different rate of the recurrences. And see, you need to see that your treatment should be tapered once there is a full regrowth and tapered, and you can substitute something else. Now, something else has not been defined. Now you have to choose, either you can give the low dose of steroid, or you can give methotrexate, or you can give apremilast. It's not been mentioned anywhere. This is in the practical, the clinical experience. I'm just telling that you can reduce the dose after full regrowth. That can happen after 1 year to 1.5 years also. and you can substitute something else to maintain this effect for long lasting. But after stopping TOFA, yes, relapse is there. You can consider as 50% relapse rate. Because we are not curing the disease. You know that even after you're using methotrexate or cyclosporine or systemic steroid, you are seeing the relapses. But there you are not seeing the wonderful regrowth, robust regrowth. Any more questions?
Yeah, I have one question, Dr. Rachita.
Yeah.
It was a very nice talk with illustrative pictures. This one, these mini pulse, no, oral mini pulse. Like, what is your experience in children, no, and between two drugs, betamethasone, I mean, betamethasone or the methylprednisolone, which you prefer, and how long you have tried in which age group?
I generally don't use systemic steroids in children. So my experience of using systemic steroid in children is limited. However, I prefer to use betamethasone mini pulse in adults. Sometimes, not regularly, sometimes. So I may not be the good person. Earlier, I used to use betamethasone, mini pulse in children very long ago. Like you can say, like 10 years ago, we have seen anthraline plus betamethasone, and we have published a study on that. But side effects and growth retardation were concern, and then thereafter I stopped using because I realized these patients keep on developing new patches, relapses, recurrences are very common despite you are using systemic steroid, but plus you are additionally hampering their growth, which is the most important part of their life.
Okay. So since you told that in tofacitinib the side effect is almost nil, can we straight away go to go for tofacitinib from the beginning in case of alopecia totalis and universalis?
That depends upon the patient's affordability also. His commitment, whether he can use it for the long period of time. Yeah.
Because the side effects with DP seems to be very high, no? So
side effects of?
DPCP seems to be very high also.
Yeah, that again, the
success rate seems to be more in this.
You have to see that affordability of even 8,000 rupees. Now, if the person is earning 30,000 per month and he is spending 8,000 rupees for child's TOFA treatment every monthly, I don't think he will sustain that treatment for a long period of time.
Okay. Yeah.
Correct?
Yes. But then, there are so many things that decides when it is affordable for which condition, because it is so much cosmetically disfiguring, no?
Yes.
People might be ready to buy.
Yeah, correct.
Yes.
If the patient is affording, so TOFA is much better than DPCP, because in DPCP, such affording patient would not like to have depigmentation on their forehead or deep hyperpigmentation. Only concern then comes with the TOFA is that they don't want to give any oral medication to their children because it is oral. I have seen, parents, they say, no, we don't want to give oral medication to my child. Give us topical. So this is, you have to judge which one to use.
Frequent visits to the clinic is also cumbersome, no? In that case also.
Yes.
Thank you. That was very nice.
Thank you, ma'am. Even though we have.
Thank you, Maya, and hello, Nirmala.
You today, and congratulations, Mumbai has won.
Oh, I didn't know. I'm in other state.
And we will see and hear more from you.
Okay. Sure. Bye.
Thank you, ma'am. It was a nice session and interaction was very good. Even though we have many more questions because of lack of time, we are proceeding to the next session.
Yeah, sure.
It is going to be a panel discussion on difficult situations in
slides, please, Vishnu.
Difficult situations in patchy hair loss and how to manage it. The session is moderated by Dr. A.V. Kaliswaran, consultant dermatologist from Dindukal. The esteemed panelists are Dr. A.J.S. Praveen, Dr. Dincy Peter, Dr. Kumaresan, and Dr. N.S. Jayanti. Once again, I welcome the moderator and all the panelists for this session on difficult situations in patchy hair loss and how to manage it. I hand over the proceedings to the moderator of the session, Dr. A.V. Kaliswaran.
Very good evening to all of you. Thank you, Dr. Padmanandan. And first of all, I want to thank TN IADVL Academy, Dr. Anandan and Dr. Nimla Devi, Dr. Anifur and Dr. Padmanandan, and IADVL President, Dr. Maya Madam, for this opportunity. So here we are going to have a small discussion on how to manage the difficult situations in patchy hair loss. Already, Madam Rachita has done a wonderful job, and Dr. Murali has really enacted how we can interpret and how to diagnose and how to manage mainly alopecia areata and other related conditions. So I welcome all the panelists, Dr. A.J. Praveen sir, Dr. Dinsi Peter madam, and Dr. Kumaresan from Coimbatore, and Dr. Jayanti. So the first question goes to Dr. Praveen sir. Sir, how will you treat alopecia areata of the eyebrow? So how will you treat it? Because alopecia areata of other sides, sometimes we have a lot of therapy, but when it comes to eyebrow, it's really some difficulty. Yeah.
First, we can give an audible, sir. Audible?
Yes, sir. Yes, sir. You are
yes, audible, sir.
Good evening. And at the outset, I thank the Academy and President Dr. Nirmala, Secretary, and Dr. Kaliswaran and Anandan for giving a wonderful show. So, as far as this alopecia areata of the eyebrows, a lot of people have this problem and it's disfiguring. First, my practical experience is I'll give a topical steroid, and in some cases, diluted intralesional steroids I'll give. That is my line of treatment. I've got good results in that.
So any panelists who want to add anything?
Sir, 2.5 milligram per ml concentration of triamcinolone is a safe therapy for eyebrows, sir. We should not exceed 1 ml at a single dose, but 2.5 milligram per ml concentration is a safe dose.
Any other drugs you specially use for eyebrow?
Dr. Kali, shall I?
Yes.
Shall I?
Yes, madam. Yes, madam. Please.
Yeah. Topical latanoprost is a very safe molecule to use, because there have been reports of blindness following intralesional steroids in the eyebrows. So we really have to be careful when we're injecting intralesional steroids into the eyebrow.
Yeah, very good input. Yes. Yeah. So eyebrow is really a special area. So probably as a first line treatment, even though literature mentions that ILS can be used on 1.25 milligram per brow, so totally 2.5 milligram for both eyebrows, it's better to avoid except in extreme cases. So topical tacrolimus, even though it's not much effective, it can work as a placebo. And bimatoprost, as madam told, it's ophthalmic solution. It has shown results in hypotrichosis of the eyebrow, so it's very safe. Probably eyebrows we have to take a little careful, because some days legal challenges are more. So better to use little less side effect drugs like bimatoprost or topical tacrolimus and ILS in extreme cases. So how will you treat DLE scalp with hair loss? This is Dr. Jayanti.
Thank you,
Dr.
sir.
Jayanti is here.
Yeah. Yes, sir. Can you hear me?
Yes, madam. Yes, you can do that.
For this hair loss in the DLE patients, definitely we have to start the treatment with systemic steroids, because this course of the disease will be very protracted and refractory. So I'll start on systemic steroids combining with hydroxychloroquine. The hydroxychloroquine will take the action only after, that is, the maximum efficacy will be after 2 months only. So I'll bridge the gap with steroids, and I'll use hydroxychloroquine. If it is good, the patient may have hair growth within 3 to 6 months, especially over the pigmented areas. That is, the surrounding pigmented areas, the patient may have the hair growth. But in case of atrophic and depigmented areas, we don't see hair growth with this treatment. If the patient is resistant to the treatment, we can use my MMF and azathioprine also. If the patient is having systemic symptoms, then the patient is going for disseminated DLE, and if the patient is going for LE, we can use rituximab and that methylprednisolone pulse also.
Any panelists who want to add anything? So, as Madam told, it's better to treat DLE as early as possible because it produces a lot of scarring alopecia. So, the main line of treatment, as already told, are sequence oral steroids, immunosuppressives, and retinoids. And topically, we can use the tacrolimus and steroid cream. And at combination, whether any burnout cases of DLE, you have tried hair transplant in permanent scarring alopecia due to DLE?
Sir, we have tried few cases, sir, but we have not seen a good growth in DLE. Like in any scarring alopecia, we haven't seen a good growth.
And other things, yes,
sir.
So DLE, because it causes a lot of tissue destruction, so probably fibrosis also occurs.
Yes.
So, so I think it's really difficult to succeed with ST. So it's better to start early on some systemic drugs, particularly sequence or some other immunosuppressives to prevent the extensive hair loss. Thank you. Thank
Sir,
you.
I would like to add on. I'm Didn't see here.
Yes, madam, please. Yeah.
Burnt out cases of scarring alopecia, if it's small, if the patient is willing, scalp reduction surgery can be done to, improve the cosmesis. It's up to the patient to decide on that. That can be done by the plastic surgeons or dermatosurgeons who is familiar with that therapy. Burnt out cases.
Burnt out cases. Yeah, thank you. It's a good idea.
Dr. Kali?
Yes, madam.
Just to add on, in recalcitrant cases of a DLE, thalidomide has also been tried and found to be successful.
Thalidomide, okay, madam. Whether you are using, madam, whether it's freely available, because even for Hansen's cases, we are not able to get it.
Not, but when it is available, probably as PGs, they should know that it is if it's available, it can.
Just for armamentarium, but whether you are using practice, madam, thalidomide for any.
I tried for one of my patients.
Because I want urgently for some of the patients for Hansen.
I know, but it seems.
Okay, ma'am. Thank you. So it's to Dr. Dinsey. So role of trichoscopy in patchy hair loss. How far it is effective in avoiding a scalp biopsy?
Definitely, trichoscopy has a major role now in along with clinical examination, clinical and history. I think that should be the first thing, and trichoscopy should be an adjunctive tool, as described by Dr. Murli effectively, like in alopecia areata and trichotillomania, and even patchy hair loss, like in tinea capitis. We have good trichoscopic findings, which could actually, along with the clinical examination, could definitely rule out the biopsy. I don't think we should in any way you do a biopsy to make a diagnosis for alopecia areata, and even trichotillomania. We have good clinical or dermoscopic findings, trichoscopic findings, which could very clearly make a diagnosis and even to differentiate between patchy and scarring alopecias.
Any panelist, anything you want to add? Any? Okay, as madam told, trichoscopy is really has become a day-to-day tool to diagnose all the common hair loss conditions. So only scalp biopsy is mainly for any suspected neoplastic conditions and others. This question is to Dr. Kumaresan. How will you treat nevus sebaceous with hair loss, local or patchy hair loss?
Sir, it's commonly seen in children. Parents bring their children with this condition, but ideally, a surgical excision and a primary closure will be a better option by a plastic surgeon as early as possible. That's a better choice.
Yeah, because why we place this question is always we have a dilemma whether to treat a nevus sebaceous with surgical or other things. As we all know that compared to epidermal nevus, sebaceous nevus may have malignant transformation in the lateral. So it serves both the purpose. So you can excise and stitch it. So you can have a good cosmetic result also. Thank you. This is to Dr. Praveen sir. So what are the investigations you want to do in a case of patchy hair loss? So common test in day-to-day practice.
First, as we said, to rule out fungal infection, KOH, hair food test, trichogram, then we have to also take a clinical photo, because the problem is the patients will initially say that they have not improved, but serial photos will help. And before that, we have to counsel the patient, because a lot of people are having stress. So in future, they have some problems. That will also help to reduce this thing. So what we do in my clinical practice is do a KOH test, see for hair pull and hair analysis test, spectrography if possible, and also see for any baseline investigation. Sometimes they have some other disease which can also mimic that. So rule out other condition will be helped. Some cases, if needed, we do some tests for the ruling out any associated vitamin deficiency, iron deficiency. To also help in not only sometimes only with patchy, they may also have anemia, other vitamin deficiency will help to reduce the hair loss. So KOH test is a must, hair pull test, trichography, this should be done. Some cases, if needed, if you want to do a special test to rule out DLE, other lichen planopilaris, skin biopsy in some selected cases.
Anybody wants to add anything? Dr. Dilsi, do you want to add anything? Okay. Thank you. So, as Sir told, KOH is common to rule out the fungus and other tests, and trichoscopy has become almost a blended tool to diagnose hair disease. So, this is question to Dr. Jayanti. So, how will you manage a case of folliculitis decalvans?
Folliculitis decalvans is a chronic disease with relapse and recurrence. And the origin of the disease may be due to a Staphylococcus aureus. So it's better to start antibiotics after the first culture sensitivity. We can antibiotic course may be needed for 2-3 times. That is the 2-3 courses of antibiotics. And we can for the recurrent folliculitis, we have to combine it with rifampicin for 600 milligram. That is also for a long, there is 10 to 12 weeks of treatment of rifampicin, provided the patient's liver functions, everything is normal. We have to eradicate the staph aureus from the nasal carriage also. And in literature, it says that isotretinoin is useful, but we have not used isotretinoin for this treatment.
Anybody wants to add anything?
And for the scarring cases, ILS, intraluminal steroids are useful in the NC.
Yes.
I would like to add on, we have used isotretinoin with good improvement, and dapsone is also a very good drug to get the folliculitis under control.
Yes, because it is a neutrophilic dermatosis,
yes.
It definitely reduces.
Some people give rifampicin also.
Sir?
You are not audible, sir.
So some people give rifampicin.
Rifampicin, yes. Yeah, rifampicin, yes. Thank you. So, as already told, follicular decalvans, topically we can use the povidone iodine shampoo and topical antibiotics like meprozin, and oral antibiotics already they have discussed, minocycline, rifampicin, and clindamycin, and retinoids in extreme cases. And topical steroids sometimes effective in burnout cases to little bit reduce the fibrosis and scarring. So, this question to Dr. Kumaresan. So, how will you treat aplasia cutis, temporal triangular alopecia? Because even though it's,
temporal triangular alopecia, hair grafting will be a better option because the vascularity will be good. This epidermis and the dermis will be in a normal shape. So, grafting hair will be a better option for temporal triangular alopecia. And even in aplasia cutis, if it's a small in size and depending on the location, we can plan the hair transplant surgery as the first option. But if it's amenable to surgical excision, we can think about the surgical excision for aplasia cutis. Otherwise, in both the conditions, we can consider hair grafting.
Whether you have done any cases which are very young in age, because these both conditions occurs at birth. Yes, patients come at a very early age. What is the youngest age you have done a HT in these cases?
16 years we have done temporal triangular alopecia. Aplasia cutis yard-based plastic surgery opinion for excision.
So as early as 16 years we can do.
Yes.
So thank you. So as already told, aplasia cutis, we all know that it's a visible erosion at birth. It's a defective skin, and sometimes if it's extensive, may need repair immediately after birth. particularly if it's very extensive and it's compromising the integrity of the skin barrier. And triangular alopecia, skin is intact, only bald patch at birth. So we can wait up to some age and we can do HT later. So this is a question to Dr. Dincy Peter. So how far trichoscopy is useful in assessing activity or severity of the alopecia areata? She is going to show some of the slides also. So how to diagnose trichoscopy images of various disorders.
I would say there are a lot of studies which have actually shown that some trichoscopic factors are useful in diagnosing the severity of alopecia areata. The most important one is exclamation mark hair or tapering hairs, broken hairs, and black dots. These are actually shows severity of alopecia areata. And if you look at the new scoring system, alopecia areata progression index, they have added these three things into the scoring. And here they have not mentioned trichoscopy, but they have just used a magnifying lens of 3x. They have, magnification to assess this. And this can
be... kindly keep the mic little closer. Yeah.
Okay. For the AAPI, alopecia areata progression index, they have used this three criteria to assess the severity of alopecia areata, and this can be used while you are follow-upping the patient. And presence of coiled hairs and short vellus hairs, regrowing vellus hairs, all this are actually good sign for regrowth. So that is also very important to document. So moving on to various, for the benefit of the postgraduates who are listening to this, I have actually put few slides, only trichoscopic pictures of alopecia areata. Please, can you one slide back? Previous slide, please. Yeah, the blue arrow shows the exclamation mark hair. The red arrow shows black dots, that is the cadaverized hairs, and yellow arrow shows the broken hair. Next slide. Again, the one exclamation mark hair or a tapering hair. And in the second slide, in the black arrow, there is a short vellus hair, and orange arrow shows circle hair, pigtail hair, or a coiled hair, which again denotes regrowth. So multiple vellus hairs, you can see that is always with treatment, you see this, and it's a good prognostic sign. Next hair, next slide, sorry. And the close differential is always trichotillomania. When you look at this trichoscopic image, you see black dots. But if you look carefully, you can see the hair shaft, the broken hair shafts are on varying length. That is, again, you should get a suspicion of trichotillomania and go back and ask history. Next slide. And here, various specific trichoscopic features like flame hairs. You can see the wavy hair residues as the hair anagen hairs is pulled out, and coiled or hook hairs or question mark hairs, which is again characteristic of trichotillomania. There are a lot of metaphoric signs which has been been described in trichotillomania. Next slide. And you can see the V sign where the hair is broken on the same length above the scalp. And again, the longitudinal split, which can be seen in trichotillomania. New signs like May sign, where the distal tip of the hair, broken hair, is bulged or thickened, has also been described. Another differential for, next slide please, is a patchy. Next slide. Patchy hair loss is tinea capitis and the non-inflammatory tinea capitis. And again, when you look at this trichoscopic image, the first thing comes to mind is trichotillomania again, because there's some haphazard arrangement, broken hairs here and there. But if you look carefully, there is a comma hair, which is shown by the yellow arrow, and like zigzag or hairs, various which is hair which is bent in multiple areas, shown in the red arrow. And the most important find, if you look carefully with the blue arrow, is transverse white bands, that is called the Moscard hair, which has been described. So this, when you look carefully, you can see all this, and it is definitely a feature for tinea capitis. Of course, we'll have to do a KOH to make the diagnosis. Moving on, just to show you one scarring alopecia, here you cannot see any follicular opening but you can see telangiectasias shown by red arrow, and follicular plugging by blue arrow, and there is the red follicular dot, and structureless white areas which suggest scarring. Next slide. And as Dr. Murali has mentioned, this blue globules or clots and dots can be seen, and sometimes you can see large yellow dots shown by the red arrows, and again structureless white area. So it's very important that we have to correlate clinical with the trichoscopic image.
So just to highlight, because nowadays it's very difficult to diagnose clinically some of the cases. So trichoscopy has improved very vastly, so we can learn and use it in day-to-day practice. So this question goes to Dr. Praveen sir. So trichotillomania, how will you convince the parents to accept the diagnosis? Because it's always very difficult. Sometimes parents who won't accept, he is normal, they will say. So how will you convince?
Yeah. This is a very nice question, because the more the problem is with the parent, they say it's only fungal infection. They don't accept that the patient is pulling the hair. I tell them, you please observe the child when she is subconsciously pulling the hair. And also there are many types of psychiatric association with trichotillomania. Some people have some tick or something to pull the hair. Some people may be associated with severe psychiatric illness. So first thing, we have to convince the adults, and also a lot of females also have this trichotillomania, adult females. So we have to convince them it's only this, and also with dermoscopy, trichoscopy, all this will help to make sure this is a diagnosis which they can accept. So we can tell them by ruling out. You can do a KOH and other studies. We can prove that it's only trichotillomania. And I think we have to slowly convince them to accept that there's a reason for that. Once people are convinced about it, and we slowly reassure them there's nothing to be worried. So gradually they'll come over it. And unless you stop the hair pulling, because sometimes people will swallow the hair, other psychological affection are there. So main thing is to convince the parents and also convince the patient that you surely don't do this. I tell them to cut the hair short, so initially, so that will avoid the pulling of the hair. So once you convince them, automatically you'll have good regrowth.
Yeah. Any panelists want to add anything?
I would like to add on the role of trichoscopy again. So I had a patient who with a past history of alopecia areata who came with, the trichoscopic images were very characteristic of trichotillomania, but both the father and the son refused to accept. And we sent to psychiatrist. Even there, they convinced them not, with a diagnosis of alopecia areata. But finally, I had to do a biopsy, and on detailed examination, the psychiatrist could find out the problem, and he was put on fluoxetine. So I think trichoscopy again here it failed, but in some, you could show the patient's relative and say these features are not suggestive of this, and it could be used to make a convince the relative.
Yeah, thank you. It's a really very good example, because patients with trichotillomania and dermatitis artifacts are really difficult to convince them and convince the parents, and we have to identify and prove them that it's the case. Thank you. Thank you. And this is to Dr. Jayanti. So how will you approach a case of acne keloidalis nuchae in a 30-year-old male with patchy hair loss? Dr. Jayanti.
Yes, sir. Actually, for this patient, 30 years old, I'll straight away after giving a one course of antibiotic, I'll go for inhalation steroid and cryotherapy. Some patients I have done CO2 laser also. For a few patients I have done. And we can use diode lasers, and for hair removal purpose we can use, and scalp reduction surgery is also useful. Hello.
Any panelists? Anybody who wants to add more? Dr. Kumaresan, any experience with the surgical thing? Any surgical with ILS?
So we generally give intralesional steroids, and for very resistant nodules we do punch excision and secondary healing. All primary closure, aggressive surgical modalities leads to a lot of hypertrophic scarring in that particular site.
Dr. Jayanti, whether you are using a CO2 laser for these cases, in what's your experience in Stanley?
Sir, very rarely we use that. For the resistant cases, recurrent cases, yes, sir.
So as told, acromegaly is sometimes very difficult condition to treat. The common approved therapies are ILS, cryotherapy, and surgery very rarely for limited area with ILS definitely. Surgery alone, if you do, definitely recurrence with a lot of scarring will occur. And of late, a lot of papers, they have shown very effectiveness of hair removals, particularly diode and long pulse angioglases in selected cases. Particularly if you intervene early, the long pulse angiog 1064 really gives good results. And diode, yes, you can use it, but long pulse angiog laser penetrates little more. So probably even a lot of publications on AAD about this long pulse angiog laser used in acne claudius UK. But you have to select the cases. So once the infection is controlled and not much of keloids, but early stage, probably you can try long pulse angiog laser to halt the disease.
Dr. Ali, do you do long pulse on the perilesional skin also?
Yes, sir. Yes, sir. Actually, the entire area because it's basically hair removal laser, but you have to concentrate because it suppose repeated sessions definitely removes hair. You should not give a picture of very sparse hair. So perilesional and lesion skin you can do, yeah, but not the entire area. Entire box, if you do, it will produce hypertrichosis. So another, because already Dr. Achita Madam told about the two effective therapies. One is topical DPCP and another biological. So how far DPCP is effective in cases of AA? What is its protocol? Dr. Dinsey, because you are using a lot in your institute.
We use DPCP when the scalp involvement is more than 50%. But as Dr. Rajita has told earlier, the patient has to come back regularly to us, like weekly. So the follow-up is not. We have few patients who had good improvement, but sometimes patients who are from far off, they can't come regularly. So that is the practical difficulty in treatment. Otherwise, it's a good option with less side effects.
How about the post-inflammatory effect you were saying?
If you actually counsel the patient, basically you have to sensitize the patient like 2 weeks prior, and we use 0.001 concentration at the scalp and make sure that the whole area is dried up, and we ask the patient to cover the scalp with a scarf and use a hat when if they are going out immediately. And we haven't encountered with a lot of meaning post-inflammatory depigmentation, so we use very gradual increment of the concentration, so to get a minimal irritant or a minimal allergic reaction, and then we continue on the same dose. So we have not encountered a lot of depigmented patients.
How many sittings you do?
Has had an article, I think, on
yes, sir.
You want to add more? Yeah.
Ma'am, I want to ask you, there are some cases who do not respond to DPCP even after like 6 to 10 sessions. They don't develop that irritant reaction. And there are some who don't develop the initial patch testing with 2% solution also. Have you tried squaric acid dibutyl ester in any of these patients, ma'am, in your institute?
No, we don't have SAD-B. So if they don't respond, we stop the DPCP.
Okay. For a few cases, I have tried squaric acid dibutyl ester. This is a chemical which is very tough to procure, ma'am. It comes under strict regulations. But even with some Western cases, they do not respond to squaric acid dibutyl also. Western cases are very tough. And there's an article on protocol and published in Indian Journal of Trichology that mentions the dilution, how to apply weekly, all the protocols are mentioned there. And apart from that, you always start with 2% DPCP, ma'am, or you dilute to 1%?
2% is only for sensitization. Yeah.
Sensation.
The other, we make that stock solution. Our pharmacy actually makes a stock solution and give us the dilution. So
in case if the patient did not get sensitized with single application of 2% DPCP, what do you do, ma'am? You repeat it or you hike the concentration, ma'am?
See, most of us patients have actually responded, but in case they haven't, we actually repeat it again. And some articles say that sometimes you may not have that severe reaction. Even then, they may be sensitized actually. So we have actually repeated in one patient. Otherwise, usually we get a irritant reaction. But
Dr. Dinsey, what is the protocol you use? Like how frequently ask them to come?
Weekly once. Actually, currently we don't have any patients on follow because it is a very long treatment protocol, and we don't usually give the medicines along with the patient. That's one. In our patients are all from far off, so to continuity of therapy is a problem.
Previously, I've seen cases of DNCB, but now they've followed. They've stopped it. DNCB.
Anybody wants to add more? Thank you. So how will you manage the case of secondary scarring alopecia? This is to Dr. Kumresan, because we are having a lot of secondary scarring alopecia due to burns, trauma, or surgical scar. Really difficult to treat because in the scarred area, medical treatment won't work. So what will you do?
For secondary scarring, among the various options or various causes, burns responds very well to hair transplant. Other causes like surgical scars, trauma, the response is always guarded. Burns, the damage is not there in the subcutaneous tissue, so the grafts are taken up very well. And all these cases, it's always better to start with fractional CO2 laser to improve the vascularity. For a couple of months, we can give fractional CO2 laser, improve the scar texture. Even for grafting smaller areas, it's easy to do. If it's a bigger area like in burn scar, we do a test patch, wait for 3 to 6 months, we'll see how the patient responds, how is the growth, then we go ahead with the full-blown surgery. Otherwise, hair transplant is a good option. We should always think of other camouflaging options apart from hair transplant, like hair pieces, hair fibers, camouflage creams, and changing in hairstyle. Everything should be combined in scarring alopecia.
Whether you have tried any hair pieces or that artificial hair pieces in these patients?
The artificial hair implantation we have never done, sir. Still, it's not yet approved because it creates.
Yes. That's not approved, yeah.
And hair pieces we routinely advise along with the surgery. While planting the grafts, we'll plant the hairs in the normal skin so that we give a hairline, and beyond the hairline, we ask them to go for a hair pieces so that from externally the hair pieces are not so visible. That gives a good cosmetic appearance.
These are the cases by Dr. Kumresan, traumatic and burn scar before and after therapy. Morphe is another already we discussed because DLE doesn't work out. How do you feel in Morphe, Hasti?
Like in primary scarring alopecias, and the response is very guarded, and there should be a last option for us. We should advise again camouflage options, changing the hairstyle. Hair pieces should be the first option, but as in any primary scarring alopecia, we look for any disease activity before venturing into hair transplant. We generally wait for 1.5 to 2 years of disease inactivity. We do multiple biopsies to confirm there is no disease activity at all. Then explain the patient, counsel them. The chance of recurrence is always there. The mere surgical procedure might trigger the disease, so everything should be explained to the patient, and then we place them into surgery. This patient is a case of morphia. After 5 years, we did a surgery. Even while doing surgery, we just planted along the normal looking skin, and very few grafts are placed in the scar tissue, so that just to give a better coverage. And these patients should be on follow-up. The disease can recur anytime, and it should be advised to the patient.
So other panels can be, yeah.
Tattooing for this camouflage.
Pardon, sir? Camouflage.
The tattooing, we don't have a very good sophisticated equipments in India, sir. It's available in abroad. We don't have those type of equipments. And for our skin, the color, whatever we fine pigment we place, it gets smudged. Due to Tyndall effect, it becomes bluish, and there is a lot of dispersion of the pigment after some time, and the appearance is not so good for tattooing in Indian skin, particularly for South Indian skin. We are finding it very difficult to do the scalp micropigmentation. Sir. In white skin, it takes up very well, but in our skin, there's a lot of practical difficulties in doing tattooing.
Black color is okay, but the only thing you can't match it to.
Matching is tough.
Dr. Kumaresan, can you do a scalp reduction in these cases?
Yes, ma'am. Scalp reduction can be done, ma'am. That's an option for us. If it's a limited area where scalp can be mobilized and resulting scar is very minimal, we can do a scalp reduction also, ma'am.
Okay, thank
you. So a lot of questions are there in chat box also. So any panelists who want to add anything more?
line, we use Lysiopolvin. It's the best drug.
Hello? Yeah.
Hello? Can I take the first question? The first line of drug we give is Lysiopolvin. We have very good response with this. Only thing, some people ask that we have to confirm the diagnosis, do a KOH and convince them. So Lysiopolvin is a good drug to be given at least 1.5 months to definitely cure period.
Thank you. Thank you. So oral Lysiopolvin and terbinafine are the approved drugs, and we are going to end. And after that, we are going to see some questions in chat box. So this is what is the final weapon you prefer in resistant or recurrent AA? This is to all panelists.
Take up.
Yeah.
Usually, if it is resistant to steroids, we'll start on cyclosporin. Especially alopecia universalis, we are using cyclosporin. It is having very good results.
Okay.
And pulse therapy also we are using, sir. Methylprednisolone pulse, and also useful.
Anybody wants to add more? Anything?
Also, you give good counseling, sir. Good counseling and make sure the patient understands the disease, so it can have recurrences, relapses. You convince them, and you can give some supportive vitamins and that in between the recurrences, and make sure you follow the protocol. If needed, mini pulse therapy or other DCPC or some other drugs. I have not used this so far, but other things we can use. Turban PUA therapy can be used, but I don't have any experience. It's noted in literature. Anybody has an idea, you can tell. Turban PUA.
Any experience in turban PUA, Dr. Gumresan?
Yes, sir. We routinely use turban PUA, sir. Particularly for children, the response, as with any therapy, it's variable, but it's a useful option. It's a steroid-sparing treatment. It's worth a try.
Sir, I would like to answer for the previous question. I think if it's a totally resistant case, we have tried or we have actually exhausted all our treatment option. I think realistically we should give a, like how Dr. Praveen said, option of wig and counseling, so that they could actually lead a normal life. Actually, many times I had actually given options, and some patients are actually doing very well with wig. So that is also one of our responsibility when it is totally resistant to therapy.
But I think in future, probably the JAK inhibitors and TOFA already, madam has told a lot of tofacitinib. So it's going really good results. So probably we may be using in another.
How's the cost of that therapy, sir? Cost?
Madam already told us, it's around 8,000.
No, the imported drug is very expensive. Praveen, so far we were only able to get Xeljanz. Xeljanz, a 5 milligram tablet of about 30 or 60, I don't know, costs about 30,000 rupees. But now she's saying this Jactor is 8,000. Probably this Janssen has come out with the Jactor. But Xeljanz is the original molecule, and that is 30,000 per month.
Especially in children, you can try, madam. Children.
5 milligrams may be less economical.
At least children, they are so much depressed, no? So you can steroid sparing drug.
Yes, it is a very safe drug.
Probably in future we may have some cheaper Indian brands. Yeah.
Biosimilars.
So tofacitinib we found promising drug. So turban PUA already they were told. And delayed anaphylaxis to lignocaine. How will you manage, Dr. Kumresan?
This delayed anaphylaxis is worrying reports of late. And two heart transplant deaths which happened in the country, both the cases are diagnosed to have delayed anaphylaxis. Surprisingly, these patients, the test dose was negative, but later the anaphylaxis was due to the local anesthetic agent. And we had a case report in the Heart Transplant Society this year, where a patient, before subjecting to surgery, was given a test dose. The patient reacted, the surgery was cancelled, and the patient was sent back. He collapsed twice in the flight. Luckily, there was no anesthetist in the flight. He revived the patient and was found to be a delayed anaphylaxis. Although this is a very rare, we should be aware that such a thing can happen. And nowadays, before surgery, we have a protocol of doing a test dose 3 days prior to the surgery. So even if it's delayed anaphylaxis, we tend to identify these patients 2 days later. And this is an idiosyncratic reaction, very tough to predict. This can happen to any patient. And one more worry is that we give a lot of local for normal dermatosurgery procedures. This can happen to us also in any dermatosurgery procedure. Although this is extremely rare, we have had 2 deaths, and the both are confirmed to be delayed anaphylaxis to lignocaine. And we should always be aware of this condition.
So you say for routine all dermatosurgical procedures, definitely lignocaine test dose should be given at least
Yes,
3
it's
days
always
before.
better, sir.
That's a good point.
That too 3 days before, sir, not
3 days
normal
before.
dermatosurgical procedures.
The previous history of any local anesthesia procedures makes us feel safe while doing any procedure. If the patient is taking for the first time, it's always better to give a test dose.
Because none of us do this thing because it's a good point. It should be emphasized. It's 3 days before the procedure you do.
So some of the questions in the chat box from the audience. So what is the experience with Androline? Already Madam Rachita told some about that. Any of panelists are you using Androline topical therapy for AA? What's your experience?
Very good response with the Androline for children, also short contact therapy along with topical steroids. Good response, like Dr. Rajita Durad said. So it is actually basically, especially in children, even in adults also, there's no, in patients with phobia of intralesional steroid, we can try this as a first line therapy.
Any particular brand you want to identify, because panelist that participant has asked about to name a brand?
We use the Derobin cream.
Yes, nowadays it's not available much. And another question is phototherapy. Already Turban Poa we have this one. Oral sulfasalazine already speaker told. Oral sulfasalazine any panelists have used?
I have used, but I did not find any improvement in a recalcitrant case.
So, any Madam Tofa you have used? Dr. Maya, Madam Tofa secretary, whether
Yes,
you
I
have
have used Tofa. I've used it in an adult, and I gave started with 5 milligrams every other day initially, and then escalated to 5 milligrams once daily. And then after that, I switched on because of the cost. That's when I knew that it was about 30,000 rupees. Then I switched on to our regular pulse steroids and methotrexate. It is very costly.
For another question is for trichoscopy, what resolution you will suggest to buy for good visualization and taking images?
Sir, I can't. Yeah, basically what we have is Haynes Delta 20 handheld dermoscope, and we have a video dermatoscope with a photo finder. But there are a lot of like Derm Light comes with a good dermoscope. I'm not I have to read up to tell you that answer. I think it will be available. Like Derm Light is a very good company which comes out with good dermoscope with attachment. So.
Almost we are coming to the end. Anybody wants to add any more question or?
For any alopecia areata, trichoscopy is definitely important, and serial test photographs. Either at least you can do a clinical photographs. You no need for, if you don't have a trichoscope, at least the clinical photographs will be useful to see the assessment. You should give the measurement. That also helps to give a psychological boost to the patient. Because more than what we have seen, we have so much psychological stress because of this. So that will help you to reduce this. And this will show that we are doing a good job about it, because a lot of people don't really see the hair and all that. They just give intralesional steroid. This will help you patient to be convinced more that to come again and again for therapy.
Dr. Kali,
yes, madam. Yeah.
Regarding the dermoscope, definitely Derm Light is a very good choice, but it is very expensive. I don't think beginners would be able to afford that. There is another thing known as Dino Light. Dino Light is almost half the price. It's about 47, and we also have some few more like Firefly and things like that. So it's not necessary that we always have to go in for these high-end models. As a beginners, when they want to really get practiced with this things, they should probably go in for Dino Light. And I'm sure the dealers are here and you should be able to.
Derma India product also is okay, madam.
Yeah, that is what a couple of affordable ones are here. For beginners, I think that should be enough.
Dr. Nirmala, do you want to ask any more question, or Dr. anybody else?
There are a lot of questions in
I
there.
think most of the questions which came for the panel have already been answered as part of the presentation itself. So I think everything is covered.
I want to ask Maya, ma'am. Ma'am mentioned about that lanthanoprost, no?
Yeah, bimetoprost, latanoprost, Xalant. We don't use, actually, when we started off, only the eye drops we were using. They are very cheap, 100, and even now we can use those eye drops. Latanoprost and bimetoprost. They are available as eye drops and they are very cheap. The dermatological ones are the ones which are really expensive. So I think we are safe.
Can we use the eye solution itself?
Yes, eye solution is more than enough. Just
what is the name?
You are using that one.
Names, brand names
yes,
for
latanoprost.
We are also using it and very good response with the
mix. Yes,
ma'am. Do you see any periorbital pigmentation with latanoprost, ma'am?
What you have to do is you have to protect the surrounding skin and then apply only on the eyebrows. It's only by touching the other parts or by diffusion in the other parts that it produces. And they have to be taught to use very less, not more than 2 drops per eye, because we are also afraid of glaucoma in case they use very excessively. So you have to warn the patients, and I have not seen periorbital hyperpigmentation. Of course, there is hyperpigmentation in the area where you apply the drops. I would like to hear more from Dr. Dincy too, because she's using them.
No, what names, ma'am, available? I mean, brand names, anything you want to?
Xalanten is one.
Xalanten.
Dr. Dincy, which are the ones you are using?
Ma'am, we have a pharmacy where we actually put the generic name and we get the brand. So I'm not aware of the brand.
Okay, so it is easily available.
Yeah, it is. Ophthalmic solution is easily available.
So how long can you use it for? I mean, you in your experience, how many months have you used? And what is the results?
Till the hair regrowth, actually, good 3 to 6 months you get good results, and we can stop.
So twice daily.
Yeah.
Okay.
Bimetoprost is also available as Bimalast. I mean, there are lots that are available. It's not.
Melanowit solution is also bimetoprost. It is available in the, I don't know the company name, but it's Melanowit for vitiligo and AA. They are.
Which one, doctor?
Melanowit solution, ma'am. But
yes. Even that is economical, right?
Last is bit costlier. Intas Pharma Lasishma. That is also little bit costlier.
Okay. Then we also had a cheaper version. Now it's gone out of the market. I forget the name. That was less expensive than.
Maybe if you inquire the ophthalmologist, they'll tell us.
Yes, your ophthalmologist will be able to.
Yeah, I should for. Okay, ma'am. Yeah. Any where from audience? Any other questions?
Any more questions? Yeah.
Annie? Any questions from the audience?
No, ma'am. All have been put here.
Ophthal brand, Lumigan.
Lumigan. Okay. Okay, ma'am.
I really thank all the panelists and the participants and the attendees for this session. And I also thank IIDVL TN Academy and IIDVL. Thank you. Thank you, one and all.
Thank you very much. A nice presentation, Khalid. Congratulations for a nice organizing, coordinating, and doing excellent jobs. Thank you.
Thank you, Dr. Kalishuran, Dr. Praveen, Dr. Kumaresan, Dr. Dincy, and Dr. Jayanti for giving us a wonderful panel discussion, and with inputs from Dr. Nirmala, Dr. Maya also. So it's a complete package that we received today. Thank you so much. We'll now have the vote of thanks by our co-chairperson, Dr. Nirmala Devi.
Yeah. So good evening to one and all. So this topic from the special focus group of IIDVL Academy and IIDVL Tamil Nadu Association. Am I audible? Well.
Yes, you are audible.
Yes, madam. Yes.
Yeah, thank you. So this topic localized the patchy hair loss alone we have taken for this session, because if we know that diffuse hair loss can be taken in another session. So we wanted to focus on this topic, and it was well conducted. And I know all the speakers have done their job justifiably well. So thanks to all speakers, right from Dr. Murali Narasimhan, Dr. Rachita, and Dr. Kali, the moderator, and the panelists, Dr. Praveen sir, Dr. Kumaresan, Dr. Jayanti, and all, and Maya ma'am, for your keynote address and the active participation in all the sessions. She's always enthusiastic, and I always draw more energy from madam. Whenever I see, when I feel lethargic, I look at madam.
No, I learned it's vice versa.
Yes, ma'am. Like it is always better to see a person who is performing more well, no? Even in spite of her commitments and the age, she will do better than all of us at any point of time. So to all of you, and I should also thank the chairman, Dr. Anandan sir, for taking us through the process with good guidance. And it may be the last, but definitely not the least, Dr. Annie. She's the workforce behind all the sessions and coordinating right from printing. So we just put messages, she makes it into the work, real work actually in practice. And so I should thank Annie well. And Dr. Padmanandan, he is very busy today, but he was able to be with us for some time. So I thank everybody, and it is not the last. I should thank the messrs of Reddy's Laboratories, because they have been the sole support for all the academic programs and for the association for the last 1 year. And I thank Mr. Vishruth and Jay for keeping with us all the time. And Dr. Dinsey, I am sorry, I might have forgot to mention. She is one of the very active panelists, especially in trichoscopy. She showed many images also. It was very useful, and it is very useful for the PGs also. So if I had forgotten anybody, it is not by omission. It's not by commission. It is maybe oversight. So I thank everybody for all your inputs and the time you have taken to make this good session, which will be useful for our practice also. Maya ma'am?
Yeah, sure. Take a photograph if everything there.
How about others? Because initial times I forgot to take, it was not possible for me to take the photo.
Find out if anybody is there, you can use it. Okay, no problem. Thank you very much. Thanks.
Annie, want to say, have I missed anybody? And I should thank
all set.
I hope the audience had a wonderful time, a good time in listening to the talks. And I think the ultimate aim of this kind of programs taken by our association is that we should utilize the brains in our state mainly. So that is the way we had academy, because we want to engage all 4 zones or all spheres of Tamil Nadu geography into the discussion. So I request all members to actively kindly participate, and if you have any interest to participate in future sessions, like we are conducting every month, this is going to be continued, and next we'll be having leprosy next soon. So like if you have any interest and if you want to participate as an the speaker or a panelist or in any form, please message to the secretary and to the convener of academy, Dr. Annie. We'll keep, we'll take you in, and Maya ma'am, you can talk to Maya ma'am also. So we all together to make all these such programs very successful. My request is for the youngsters to take part actively. Don't think that we are only the seniors, the oldies are talking. We want to look out for bright youngsters to take part in all them. What ma'am? What do you say? This is our purpose, because the academy is not for only people who are in the association working as a secretary, this and that. It is for you to come and utilize the opportunities available with us within the association. It's not just only for the youngsters. There are a lot more to come in future from our state association also. So this is my request. All of you, please feel free to contact the secretary and the convener of the academy if you want to participate in any form in the future webinars. So with these words, I take rest. Thank you, all of you. Good night.
Good night. Excellent job, all of you. Jayanti, hello Jayanti. I didn't see you.
Yes, ma'am.
Nice, Jayanti. Looking cute.
Dr. Jayanti, sorry, have I forgotten? I think I told you the panelist name.
No worries.
நீங்க bright-ஆ இருக்கீங்க.
முலாம் பூசிருக்கேன்னு நினைக்கிறேன் நிறைய.
Saree super, ma'am. Maya ma'am, saree.
Vishnu, we can go offline, right?
I'm admiring yours.
Yeah, just announce
ma'am,
that.
I'm admiring yours.
Thank you all.
Yeah, thank you.
Excellent job, Kali.
Thank you, madam. Thank you all because your support. Your inputs are very much useful.
Questions actually.
எல்லா பாயிண்ட்ஸும் ஐ திங்க் patchy alopecia ஓட எல்லா இதுவுமே ஓவராலா கவர் ஆயிடுச்சுங்க. நிஜமாவே பிஜிஸ்க்கு எல்லாருக்குமே நல்லா.
All the panelists they
the thing is they should listen to all these talks without wasting their time in other things. That is what is the thing.
How many people participated?
அதுனா தெரியல.
Around 200, madam. Around 200.
Yeah, that is the good number.
Good number for.
There is actually another program also, I think now between 7 and 8 I saw.
Yes, no, Janssen, the same Janssen company is from 6 this evening, and one of the speakers is our Tamil Nadu Chennai speaker. Soumya no edo basics.
Lot of
Harlas, ma'am. Harlasa. Where some program I saw somewhere. There is some program now at the same time. Anyway, hair always draws attention. It's an important cost organelle.
Excellent program.
Ma'am, next month we have, I mean, there is a AIDS day coming up, no? December.
Yeah, we'll ask Dr. Murugan.